It gives me great pleasure to introduce our speaker today, Dr. Becky Ma. She joined the Department of Medicine, School of Clinical Medicine, the University of Hong Kong in December 2024 as Clinical Assistant Professor of Practice. She received her MBBS degree from Hong Kong U and completed her training in nephrology and advanced internal medicine at Queen Mary Hospital and Donghua Hospital, followed by a very prestigious postdoc research fellowship in precision medicine at Columbia University Center for Precision Medicine and Genomics. Dr. Ma has great interest in genetic kidney diseases. She has been awarded the HMRF Research Fellowship Grant and, importantly, the Hong Kong College of Physicians Hong Kong Genome Institute Training Grant for Excellence in Genomic Medicine. Dr. Ma helped to establish the Genetic Kidney Disease Clinics at Queen Mary Hospital, which aims to help patients with genetic kidney diseases to achieve accurate molecular diagnosis and derive personalized prevention and treatment strategies. Dr. Ma is also part of the very important ClinGen working group on kidney cystic encephalopathy disorder and Alport syndrome variant curation expert panel. Today we are very lucky. Her talk is titled Hong Kong Genome Project Case Sharing, Precision Medicine in Nephrology. Dr. Ma, please.
So today's presentation is titled Genomic Medicine for Kidney Diseases. So before dwelling into this topic, let me first of all talk briefly about this very important organ in our body, the kidneys. So normally each of us has two kidneys, each located on one side of our spine, and it's approximately the size of a fist. Despite it being very small, it is perfused with around 20% of the cardiac output and form around 180 liters of ultrafiltrate every day. And there is its profound alteration in terms of the components of the ultrafiltrate, and the majority of them are being reabsorbed. So that will produce around 1 to 2 liters of urine output every day, depending on the hydration status. And each kidney contains around 1 million of nephrons, which are basically functional units of the kidney. And the structure is illustrated on the right-hand side. It's just like we have two factories, and we've got 1 million workers in each factory, constantly working every day. Our kidneys have very important function. It's important to regulate water balance and hence control blood pressure. It's important for regulate electrolyte balances and acid-base balances. It's important for the uptake of the proteins to regulate the metabolic clearance and also hormone homeostasis, and hence has this metabolic and endocrine function and also immune function. And hence patients who have kidney dysfunctions can experience a range of symptoms and signs, not only limited to the kidneys. They can have gastrointestinal upset, chronic fatigue, neurological symptoms, cardiovascular diseases, skin disorders, fluid overload, have this shortness of breath or bilateral lower limb swelling, etc. So a kidney disease is never limited to the kidneys. The patients experience a range of symptoms. But our kidneys have good compensatory mechanism that in the early stage of disease, it's just like in the factory, if one worker is sick, then the remaining can still compensate for the job need. But if the majority of the workers in the factories are not working, then the productivity will fall, and then the patients will start to manifest symptoms. So that in the early stage of kidney disease, patients can remain relatively asymptomatic. And hence, that's what we call chronic kidney disease, very often a silent killer. When the kidney injury persists for 3 months or more, then we call it chronic kidney disease, in short term CKD. And based on the glomerular filtration rate and also the albumin level, we divide them into different stages, with stage 1 being the early stage, and stage 5 being what we call the end-stage kidney failure or end-stage kidney disease, that patients' kidneys are no longer functional, that we would need replacement therapies such as dialysis and transplant to replace the function. Every 1 out of 10 adults actually are being affected by chronic kidney disease. And there is constant rise in the incidence and prevalence of CKD that is one of the largest projected increase of any major cause of death. And hence, the World Health Organization has just passed a resolution emphasizing the importance of combating chronic kidney disease worldwide. So CKD comprises of both monogenic and polygenic etiologies. Monogenic forms are due to rare pathogenic variants on a single gene that has a significant effect size. It causes around 70% of end-stage kidney disease in children and around 10 to 15% of end-stage kidney disease in adults. And on the other hand, side of the spectrum, you can see polygenic causes, which means that there are common variants that each has a small effect size and cumulatively will increase the risk of disease, such as IgA nephropathy, which is the most common glomerulonephritis in Asian patients. And there is a group emerging in between, which is the risk allele, or what we call the low penetrant variants. And one good example is the APOL1 related kidney disease in patients with African ancestry. I still remember during my trainee days in nephrology that we have so many things to study, including various types of glomerulonephritis, the treatment, the kidney biopsy findings, and different modes and modalities of kidney replacement therapy. But there was so little to talk about this monogenic kidney disease, and it was because it was thought to be so rare. But with this rapid advancement in sequencing technology over the past decade, there have been multiple national cohorts being performed across the continents that have actually shown that monogenic kidney disease are not that rare as we previously thought. For example, in this landmark paper published in 2019 in the New England Journal of Medicine, the Columbia group showed that more than 10% of patients with chronic kidney disease actually have a monogenic etiology. And many of them were misdiagnosed previously as having some non-specific diagnosis, such as hypertensive nephrosclerosis. And hence the question arose to me is that we've got these so rapidly advancing technologies in genomic medicine. How can we use these tools to help the patients that we see every day in clinic and in wards? So let me share with you the story of one of the patients we previously took care of. She's a 24-year-old lady. She's completed school and had a short-term job, but found it too stressful, so she quitted the job. She presented with this fatigue for 2 months' time, and during that period, she thought it was initially due to the stressful work, but it persisted and got worse. So she presented to a family doctor. Otherwise, she has good past health, just short stature noted since childhood. And she told me that it was thought to be normal during school checkups because both her parents were also short. So the family doctor helped to do some baseline investigations, and she was immediately referred to the accident and emergency department because of the very alarming blood results. As you can see that her estimated glomerular filtration rate at that time was only 3, which correspond to stage 5 kidney disease, which is end-stage kidney failure. So we did the workup, including the urine, the ultrasound, and also the serology, etc., all the standard workup that we would perform for patients with chronic kidney disease. And I saw that she had a bit of proteinuria. The ultrasound showed bilateral smallish kidneys already, which meant that the chronic kidney disease has been for some times already. It's not happening in only 1 to 2 days or weeks. And the serology, is actually all the standard investigations, were unremarkable. So I still remember seeing her in the intensive care unit. She was alert and conscious, fully communicable at the time, but because of the gross abnormalities in electrolytes and acid-base balance, that she was admitted from the accident emergency department directly to intensive care unit and subsequently started on dialysis. I still remember talking to her of the investigation results that we've so far found and the next step that she would be expecting. In patients with end-stage kidney disease, there are a lot to plan for and to expect because the kidneys are not functioning, so we need a method to replace it by either dialysis or transplant. For dialysis, it could be peritoneal dialysis or hemodialysis. That patient would need a catheter implantation. There is the risk of anesthetic risk, surgical risk, and also subsequent complications like infections, and also the arteriovenous fistula that is needed for hemodialysis quite disfiguring for such a young lady. And also she needs to dedicate a certain period of time in life to do this dialysis. For example, performing peritoneal dialysis, it's on an everyday basis. And doing hemodialysis means 2 to 3 weeks, 2 to 3 days, half days per week, being bound to the dialysis machine. Think about what it has, like the impact on her life at this golden age of her life, the impact on her family planning, career planning, and also all the social life. So it's hard to actually break the bad news that her kidney disease is already end stage, it's irreversible, and she would need to face all these different modalities. And she kept asking me why. What happened to her kidneys? What caused the harm? Why at this age she already has end-stage kidney disease? And unfortunately, I couldn't provide an answer to her parents, and to her sister when we saw the family in the intensive care unit. So what I could say is that after standard workup, we know that your kidneys are not functioning. We've got ways to replace the function, but to be honest, we really don't know what's the enemy that's out there that we need to tackle that cause the kidney disease. So subsequently, we had the genetic evaluation. We helped her to do the counseling. It also did the genetic testing, which is very much the last resort that we have. And the results came back that she harbored 2 likely pathogenic variants on the CEP290 gene, which is compatible with the diagnosis of autosomal recessive nephronophthisis. It's a kind of chronic tubular interstitial nephritis, which basically means the inflammation in the kidney's tubular interstitium. It is caused by one of the 21 genes, mutations, and CP290 is one of them, that causes this progressive decline in kidney function. And patients can be relatively asymptomatic or have this mild, non-specific symptom in the beginning, such as feeling thirsty all the time or kind of frequently going to urination. And patients typically progress to end-stage kidney disease at a rather early age, before 30s, and it's also associated with a growth restriction. So as you can see, it seems simple to kind of present the result in terms of the lab results, the genetic finding result. But in reality, it actually takes the whole team's work from the patient's presentation to actually obtaining the results, from the clinician being able to identify and refer these patients for genetic evaluation to genetic counselors or other specialists who have expertise in counseling to actually talk to the patient and explain the pros, cons, indications, risks of genetic testing and obtaining the consent, to the bloods being taken, the laboratory team having expertise of doing DNA extraction and subsequent sequencing, and bioinformatics pipelines, and subsequent variants curation manually, and having this multidisciplinary team meetings to discuss a complicated case, to finally getting this result that can actually help the patient. So it's really a team's effort to make it possible. So we can finally answer her question of what's happening to her kidneys, that she's got this nephronophthisis. Subsequently, we arranged the parental testing to confirm the biallelic inheritance and also search for subtle extrarenal manifestations, because nephronophthisis can be associated with a range of extrarenal manifestations. So she did report to us some night vision problem, not being able to see clearly at night. So we referred her to ophthalmologists who later on diagnosed her to have retinitis pigmentosa. And also, one good news of getting this diagnosis for her would be that the transplant prognosis is actually quite good. The disease does not recur after kidney transplant. And also, her sister can be a living related donor despite being a carrier. And one important lesson to learn also from this patient is that for patients with chronic kidney disease, the kidneys are usually not alone. Patients may have some extrarenal manifestations that are really worth detailed search. So this was not the first patient that I saw. I remember seeing quite a few patients previously who also have been labeled as having chronic kidney disease of unknown or uncertain etiology. And thinking about the renal constitution, so just flipping through the medical records of our patient, we do see quite a number of these patients having CKD-X, that they present to the nephrology care with advanced CKD, and after a standard workup, the cause was still unrevealing. And some of them have this kidney biopsy not feasible because of the mid to late stage of kidney disease. So I wondered at the time, what was the cause of the chronic kidney disease in these patients? And can genetic testing help these patients? And if so, how can genetic testing help? And hence, we initiated this study to investigate targeted whole genome sequencing in adults with CKD-X in collaboration and support from the Hong Kong Genome Institute. Unfortunately, we've also got the support from the HMRF Research Fellowship Scheme at the time. So here is the aim of the study. So we basically recruited patients with this diagnosis of CKD-X from October the 1st, 2022 to June the 1st, 2024. And we recruited all adult patients followed up in our nephrology clinics. And patients who have this definite diagnosis of CKD cause would be excluded. And after assessment of eligibility, we finally got 131 patients with genetic testing results available. So at the time, we curated a new kidney disease gene panel, as there are constantly new genes being discovered to be associated with kidney disease. So what we did was use OMIM, the genitourinary phenotype, and look for those with only genuine gene disease association, and shortlisted 638 genes. And here is the demographics of our cohort. You can see that we have a fairly young cohort. with a mean age at clinical presentation of only 35. But the age at recruitment was 48, which means that there's a 13-year lapse in between the clinical presentation to any suspicion of a monogenic etiology for the cause of kidney disease. We've got a bit more males, and the majority are Chinese. 21% of the patients had end-stage kidney disease already at clinical presentation, and 23% of the patients had kidney biopsy performed. The majority did not have kidney biopsy performed, which is considered the gold standard of diagnosis, because they either present rather late with advanced stage of CKD, that kidney biopsies are no longer feasible, the kidneys are scarred, small, kidney biopsies are risky and not yielding. Or the kidney biopsy was deemed to be too high risk, or patient refused, or patient had this microscopic hematuria with stable kidney function, very low grade proteinuria, where kidney biopsy was not considered. So you can see that 36% of our cohort patients actually have a positive family history of any forms of kidney disease, and 24% had this family history of CKD-X. And here are the positive genetic testing results that we got from our cohort. We identified pathogenic and likely pathogenic variants in 13 patients, making a diagnostic yield of 10%. So every 1 out of 10 adults with this previously being labeled of CKD-X actually have a monogenic cause. And you can see a range of spectrum of the cause of the kidney disease, being with collagenopathy being the most common, followed by ciliopathy. We've also got a few patients with atypical polycystic kidney disease. So Alport syndrome, or the collagenopathy, is actually the leading cause of CKD-X locally. And interestingly, when we kind of compared the different demographics between those with positive genetic finding versus those with negative genetic finding, you can see a significantly higher proportion of patients with positive genetic findings actually have a family history of kidney disease or chronic kidney disease of unknown etiology. But one thing to take note is that still 23% of patients who have positive genetic finding do not have a positive family history. So a negative family history cannot preclude or exclude this genetic diagnosis or suspicion. So over the course of the study period, we helped 131 patients, did targeted whole genome sequencing, and the diagnostic yield was 10%. And we identified that Alport syndrome is a leading cause of local CKD-X population, followed by renal ciliopathy, and a family history of CKD-X predicts positive genetic finding. There have been other cohorts being done across the globe. As you can see, only a few in the past 1 to 2 years being published. And the majority of the patients were Caucasians. There is one Asian cohort, that was the Japanese cohort. The diagnostic yield was around 10-11%. So the diagnostic yield is quite variable and really depends on the cohort selection. Our cohort was rather an unselected cohort that reflects the patients that we see with CKD-X in our daily nephrology clinics, while some of the cohorts recruited patients who were young, include pediatrics patients, or those who had end-stage kidney failure presenting before a certain age. So it's a very valuable piece of information for our local patients. And genetic diagnosis is useful in uncovering the unknowns in nephrology, with CKD-X being a good example. And the clinical utility of a positive genetic diagnosis is becoming more and more evident. So it's kind of considered an upfront diagnostic tool, the genotype first approach. and in some patients, maybe even before invasive procedures such as kidney biopsy. So in the following time, I'll talk about this Alport syndrome, which is the most common monogenic cause of CKDX in the local population. So patients with Alport syndrome have these mutations in one of the 3 genes, and these genes are important to form the heterotromer network of the glomerular basement membrane and gives this the tensile and compressive strength to prevent the leaking of blood and also urine in blood and also protein in the urine. And you can see here are the 3 genes, the collagen 4, alpha 3, 4, and 5, and they've got different modes of inheritance. So patients with Alport syndrome with these mutations will have abnormalities in the glomerular basement membrane, which is basically a filter of our kidney. And hence they will have blood in the urine, protein in the urine, and progressive deterioration in kidney function to end-stage kidney disease. And this is not only affecting their kidneys, but also the eyes and also ears, because these structures are found there as well. So there are multiple clinical trials ongoing for targeted treatment for these patients. And one important message is that we have been using RAAS blockade, the traditional renal protective medication in these patients. And it has been shown by multiple studies that early initiation or timely initiation of this drug, particularly in those patients who have been genetically confirmed and start to manifest with microscopic hematuria or proteinuria, can actually delay the time of starting dialysis or transplant. Previous study by a well-known German group actually showed that timely initiation of this drug can actually delay the median age of dialysis or transplant by 3 years among those patients who have kidney impairment, and by 18 years among those with proteinuria. So imagine 18 years of life without dialysis or transplant being gained if the diagnosis is made timely and early enough. So in the following time, I would like to share another patient that we've managed. She's a 25-year-old lady. She presented with bilateral lower limb swelling for 1 month, but otherwise had good past health. Again, upon presentation, you can see that her kidney function was rather deranged with an estimated glomerular filtration rate of less than 10. The urine showed some red cells and also a bit of protein. And again, the ultrasound showed bilateral smallish kidneys with increased renal parenchymal echogenicity, which is a sign that it's already chronic. And all the standard workup, including serology, were quite unremarkable. And again, kidney biopsy was not feasible at the time, and the patient was labeled as end-stage kidney disease of unknown cause. And upon further questioning, she has a strong family of chronic kidney disease. Her mother, 3 sisters, and also 1 brother all have chronic kidney disease, and they were of unknown cause. So we helped the patient to do genetic evaluation followed by counseling, and we identified a collagen 4 alpha 3 likely pathogenic variant, which is compatible with autosomal dominant Alport syndrome. So in patients with Alport syndrome, having a molecular diagnosis has multiple clinical implications. It helps to end the diagnostic odyssey in the family, not only limited to the patients. The patient's family and herself has been having this chronic kidney disease for many years without knowing the exact cause to what's the reason. And also, it helps to guide physician to screen for extrarenal manifestations such as eye abnormalities or hearing abnormalities. So timely referral to a specialist can be helpful. And also it guides the treatment options, as seen in the previous slides, that early and timely initiation of renal protective therapy can actually delay the timing of starting dialysis or transplant. And also, it's not uncommon that we've encountered quite a number of patients who have been misdiagnosed to have other disease entities, because Alport syndrome can mimic other disease, such as focal segmental glomerulosclerosis, and patients have been started on inappropriate treatment, such as immunosuppressive therapies, and they really have multiple short-term and long-term side effects. And also, it guides prognosis, as different mode of inheritance and different mutations on these three genes actually have different prognostic information provided to the family. It's also important to inform the transplant risk. Again, Alport syndrome, for patients receiving kidney transplant, the prognosis is actually quite good, that it does not recur in the transplanted kidney. But one thing to take note is that after transplant, particularly in those patients with truncating mutation, that they've never been exposed to this antigen, so that the body would develop antibody against the glomerular basement membrane after the transplant. So if after transplant there is a deterioration in kidney function, one needs to think about this anti-GBM disease as a differential diagnosis. And also, it helps to inform the donor selection, as it's recommended that patients' relatives who harbor the same familial variant, it's recommended not to be a living donor. This is because of the risk of future kidney failure. And one can imagine, again, the implication of this. If one's sister, brother, parent, or children donated a kidney and later on found out that he or she is going to experience the same pathway of chronic kidney disease and stage kidney failure as the patient, what does it have the psychological impact on both the donor and also the recipient, and maybe family dynamics? And also, it's important that the genetic diagnosis can guide this family planning, particularly with more advanced technologies such as pre-implantation genetic diagnosis and also in vitro fertilization with embryo selection, and also can benefit other family members via cascade testing, so that their children can be diagnosed early on and started on appropriate therapy early on to delay the kidney disease progression. So this is one of the letter to the editor that I previously read, and I find the story very touching. It's written by a patient who has Alport syndrome, and she has been misdiagnosed to be having another kidney disease entity even after previously had this kidney biopsy done. And she was started on immunosuppressive therapy, steroids, and she described her pathway of this misdiagnosis and how steroids had led to her emotional disturbances during her teenage year. As you can imagine, the side effects of steroids being puffy, Cushingoid, and patients having striae develop in a shorter period of time. And later on, she got this correct diagnosis finally. So she said, our journeys are scattered with misdiagnosis, missed opportunities for accurate diagnosis, counterproductive medications, and overwhelming guilt when our children are diagnosed. Accurate diagnosis opens the door to important options such as understanding recommended treatment guidelines from experts, identifying other family members at risk, awareness of potential complications for monitoring or treatment, and the opportunities to participate in research. And we've encountered many similar stories in our daily clinical practice. They are similar in a way, but each of them is actually unique. So for our patient, no matter it's from the presentation to the short-term bridging to dialysis, to later on that she's got a kidney transplant being performed, you can see the importance of getting this genetic diagnosis of Alport syndrome in each step of this proper management of her medical illness. And apart from the purpose of diagnosing underlying kidney disease, we've also tried to explore other benefits of genetic testing in patients with kidney disease. As we know that kidney transplantation is the best treatment modality in patients with end-stage kidney disease because of prolonged survival and also better quality of life compared to patients staying on dialysis. However, with all these new immunosuppressive agents, they still have a number of side effects, and patients need to be put on them lifelong to protect the allograft and prevent rejection. And these patients actually suffer from multiple comorbidities, including cardiovascular events, including cancer, and also various types of infections, no matter it's early post-transplant or long-term opportunistic infections. So at the time, we tried to develop a transplant morbidity gene panel that was selected genes associated with these post-transplant comorbidity conditions. And we evaluated the panel in 1,590 patients, kidney transplant recipients, using their whole exome sequencing data. And the diagnostic yield was up to 9.1%. Again, nearly 1 out of 10 of these kidney transplant recipients actually have a monogenic condition that are associated with the post-transplant comorbidities. So here is the transplant morbidity gene panel gene list. There were some overlaps between the kidney disease gene panel and also the American College of Medical Genetics secondary findings gene list. And this is the detailed genes that we evaluated at the time. You can see the diagnostic yield was the highest for patients with cardiovascular disease-associated genes, followed by malignancy, followed by immunodeficiency, and lastly, thrombophilia. And reviewing the clinical implication of having this diagnosis on post-transplant care, these genetic findings would allow physicians to set specific risk factor targets, arrange intensive surveillance, utilize preventive measures, guide disease-specific therapy, initiate specialty referral, and also alter immunosuppressive regimens. One example is a patient with familial hypercholesterolemia being genetically diagnosed. Then it will allow a physician to set stringent lipid profile target, rapidly intensify the treatment, refer to specialized clinic, and also modify the immunosuppressive regimen, such as steroids minimization, and also preferential use of one immunosuppressive agent to the other. So the diagnostic yield may be even higher with more advanced sequencing technologies, such as whole genome sequencing, long-read sequencing. And this is mentioned in the editorial that came with our publication. And also, that the gene panel can also be further expanded and updated and to include other interesting comorbidities after kidney transplant, such as obesity, epilepsy, hemostasis, etc. And also, there is new evidence that now backs for a more comprehensive genomic assessment being integrated into the kidney transplant assessment process to both the donors and also the recipients. So this is a brief look into the future. So with all these evidence and also demands, so we've established our genetic kidney disease clinic at Queen Mary Hospital that will help the patients do pre-test genetic counseling, followed by ordering appropriate tests. And then the test is done by the chemical pathology lab. And then we have a multidisciplinary team meeting to discuss that, and also to return the post-test genetic results, refer to appropriate specialties, and do cascade testing for other family members, and actively recruiting patients for various research projects. But there are still many challenges that we face. For example, the variants of uncertain significance, when is it the best timing for testing in children, for typically adult onset disease, and also these gaps, inequities in terms of access to genetic testing and also therapies. But the future is also hopeful that there are more advanced and also rapid sequencing technologies. The genomics are being used to drive drug discovery and also therapeutic development in patients who have been diagnosed to have monogenic kidney disease, for example, in patients with polycystic kidney disease or primary hyperoxaluria. So with this slide, I would like to end today's talk. I would like to thank our entire Hong Kong West Cluster renal team for all the support and also help and referrals. And also I would like to thank the Hong Kong Genome Institute, and particularly I've got the support from the Hong Kong College of Physicians, the Hong Kong Genome Institute training grant for excellence in genomic medicine. So at the time, I had a dedicated period of time that I can really devote into learning and training. And I'm really thankful to all the expertise here, the entire collaborative team to help to train me and also teach me. There was intensive exposure to genomic medicine during the period of time, from various curation to joining multidisciplinary team meetings to actually going into the wet lab and also seeing the bioinformatics pipelines. So understanding the whole process so that I'm better equipped with the knowledge and also the skills that can bring back to our real clinical setting in helping our patients in the clinics and in the wards. And also through all these discussions, spark new ideas for research that in the future we hope to be able to better advance the technologies. And also I would like to thank our other local and also international collaborators for all the help and support. And we'll welcome referrals to our genetic kidney disease clinic. Thank you very much.
Thanks a lot, Becky, for this wonderful talk. And all of you can really see medicine in motion. It's a very dynamic field. Although nephrology is a discipline that has been with us for many decades already, now with the impact of genomic medicine, you see new ideas. How we use genomics to help to explain patients with end-stage renal failure, and how we can prepare our patient better when they go through a major procedure such as renal transplant. I'm sure there would be questions. Is there any questions from the floor?
Yeah, thank you, Dr. Ma, for the very excellent talk. We really learn a lot, especially I'm also involved in analyzing part of the CKD cohort. So I guess I have two questions. The first one will be, so you also mentioned about the the timing for testing the children. Given Alport syndrome is not really a traditionally like a childhood onset genetic disease, what's the consensus of your in your expertise that should we really test the children if the parents that get diagnosed as soon as possible, or we should wait till they get into adulthood?
Yeah, thank you, Wei, very much for the question, and thank you very much for helping with the CKD cohort, all your effort. So I think that's a great question, and there have been some ongoing debates about when is the best timing to test these children. So for Alport syndrome, there have been the collagen 4, alpha 3, alpha 4, alpha 5 genes, and there could be the autosomal recessive, the X-linked, and also dominant forms. But then the autosomal dominant forms is kind of like more milder forms, but the range of disease spectrum can really be quite wide. Some patients can present with kind of like microscopic hematuria throughout life with preserved kidney function, while others can have this rather progressive kidney function decline, progressing to end-stage kidney failure. So it's still very difficult to predict at this time in terms of the exact onset of time of these patients. But the consensus is that for patients with autosomal recessive and X-linked forms of Alport syndromes, patients tend to present really early and then say that in the 20s they already need to receive kidney transplant or dialysis. And previous studies have really shown good evidence in support of this early diagnosis. And once the patient, for example, have this diagnosis, and then they need to be regularly followed up, and then their urine tested. And once there is only microscopic hematuria or proteinuria appearing, then they should already be started on renal protective therapy like RAAS blockade, and it can actually delay the onset progression to end-stage kidney failure by years compared to their peers who have not been kind of like timely treated. And yeah, I think it's really a great question to kind of consider the pros and then also the balance of this uncertainties, I would say, also in the genomic field. Yeah.
Thank you. So any other questions from the floor? Well, in the interim, let me share a case, a very interesting case with you. I have actually seen a couple in prenatal diagnosis clinic with the questions of Alport syndrome in mind. The lady actually and the husband actually go through expanded carrier testing and find out that the lady actually have an Alport syndrome gene. But the laboratory have problem deciding whether the mutation on the collagen 4 is an AD or an AR form of Alport syndrome. We actually searched the latest literature. Nowadays, the new thinking about this is a semi-dominant kind of condition, whereas sometimes you have one mutation, you get a milder form, just like what you have mentioned, and then if you have an AR kind of situation that you have two mutation, the severity of the condition really goes up. So only with all these advancements in understanding, we would be able to give the lady a more accurate kind of prediction about what would happen to the fetus. And interestingly, is through this exercise of finding whether she is a carrier of certain autosomal recessive disease, because she have that mutation, she went through some workup, and that lady indeed had microscopic hematuria. So from the initial thoughts of doing a carrier screening for the next generation, she actually gained some understanding about her own health, and now she needs to be seen by the nephrologist to optimize the care. Luckily, she discovered that before end stage, she is still very mild. And I think the surveillance and the treatment like the ASS blockade that you mentioned would have helped to protect her kidney a little bit better. Do you also see referral from not patients with impaired renal function, but just like what I have said, prenatal and other situations?
Yes, thank you, Brian. Yeah, that's a great sharing. I remember recently actually seeing one patient who got this natal basically diagnosis. She had this extended carrier screening, and she was pregnant, and then she did this carrier screening, and then there was a collagen 4 alpha 5 pathogenic variant that actually kind of like help her identify. And then she revealed that she actually had a prior history in mainland China of having microscopic hematuria on the lab results, but then she didn't have follow-up subsequently. So it's kind of like all these like referral because of one pregnancy screening, and then led to kind of like the continued care of her, proper care, and also proper diagnosis of her having Alport syndrome. And then we had this counseling, and then she was considering in early phase of pregnancy of whether or not to continue, because collagen 4 alpha 5, if she's carrying a boy, can be quite severe. That patient has this early onset of microscopic hematuria, proteinuria, end-stage kidney disease, and also extrarenal manifestations like hearing and also visual problems. So yeah, she was considering that. So I think it really, this case also illustrates the kind of importance of getting a proper diagnosis, particularly knowing, for example, which gene, the mode of inheritance, etc.
Thank you.
Yeah.
Is there any other questions? Johnson.
Hi, Dr. Ma. This is Johnson. Yeah, thanks for the sharing. So thanks for sharing all those. You shared a lot of cases of monogenic diagnosis of the CKD diseases. You also, in the early part of your presentation, you show a picture. Actually, for CKD, there are two types of genes. One is monogenic, high and very rare variants, but highly pathogenic. But there's also another type of variants will be common variants. is polygenic genes, so which can be used for polygenic risk calculations. According to your point of view as a clinician, what would be the benefits for calculating a polygenic risk score for the patients and for the non-patients who want to just do a screening? What would be the benefits for them?
Yeah, thank you, Johnson, for that very interesting question. I think there is a growing interest in polygenic risk score, and there have been a few large cohorts of patients studying polygenic risk score in patients with chronic kidney disease. And it has been shown that in those patients with rather high polygenic risk score, their chronic kidney disease risk is actually 3 times compared to those that have lower score. So I think there's a working effort in terms of integrating the polygenic risk score in real clinical practice. But I think more work needs to be done in terms of validation different population cohorts, and also this kind of distinguishment in terms of high versus low and what's the cutoff. And also another interesting aspect would be integrating polygenic risk score with monogenic kind of diseases, and how polygenic risk score can actually modify the kind of disease severity in patients with monogenic diseases.
Thank you. So I just want to follow up on that. Becky, you did mention in the very beginning of the talk of the evolving news story about the APO gene in African population. Can you enlighten us more on that? I think that is a big story in nephrology around the world recently. Can you share more with us?
Yes, thank you, Brian, for the great question. So I think the APOL1 was kind of initially discovered in terms of patients with African ancestry. They have a significantly higher proportion of them having chronic kidney disease, and also in certain diseases it was found, for example, in the HIVN, the HIV-associated kidney disease, or in lupus nephritis, or in focal segmental glomerulosclerosis, that patients with this APOL1 risk alleles, that they have a significant higher risk, sometimes like the odds which is up to 20% higher risk of kind of having these kind of kidney disease. And this was kind of developed or evolved as a protective measures to the parasitic infection in the African ancestry. And I think this was made possible for the discovery really because of large population cohorts in the American, the African Americans being sequenced, and then they were able to identify these risk alleles. I think Genome Project is really a good initiative to identify our local Chinese kind of variants and genomic data, and if there's any uniqueness in our own kind of population. And of course, like no matter all these, there's increasing or enriching population data, and I think locally we're really kind of adding and also benefiting our local patients with all these genomic sequencing data available.
This is why we all think that we need to do our own homework when it comes to genomics and genomic medicine. This is the beauty of genomic diversity, and I guess it's because of the good work done in North America that they start to see this very interesting but unique genetic change that offer a different kind of risk to African patients on kidney disease of various nature. And I just read from some of the recent news that actually this test becomes a clinical service in NHS for patients of African descent.
Yes, and also there have been like more studies built on to this discovery in terms of, say, transplant assessment, donor allocation, also treatment developed targeting this risk alleles.
Yeah, and this is actually answering what also Johnson was talking about. It's polygenic, but then some genes appear to be more important compared to the other. And even the discovery of one gene allele would be very helpful clinically if we are able to study the impact and the odds ratios associated with that allele.
Yep.
I want to see if there is more questions from the floor. Dr. Low, you would like to ask something?
Yeah, thank you, Becky, for a very informative presentation. My question centers around the Genome Project and your cohort of the chronic renal disease patient. whether by doing a very small cohort, you have actually observed different types of the renal disease for Hong Kong Chinese as compared with those of the Caucasian. And the second question relates to the observation that you have made for the transplantation gene panel. And you mentioned cardiovascular gene panel is actually of the highest frequency, giving you the problem post-transplant. Dr. Brian Chung will say more about what we have seen in the local Hong Kong Chinese for the local cardiovascular gene allele frequency, and that may tie into your observation there. But the first question is whether there is any difference in local Hong Kong Chinese renal disease that you have seen that are different from the Caucasian. Thank you.
Thank you very much, Doctor, for the excellent questions. So I think in our cohort, what is different is that, first of all, we've got more patients of this clinically diagnosed to have IgA nephropathy. And IgA nephropathy patients are typically known to be more prevalent in Asians compared to Caucasians. But then it was found that patients having IgA nephropathy not only have IgA nephropathy, for example, being evidenced by kidney biopsy, but also concomitantly have a monogenic finding of Alport syndrome. So sometimes it's not really being misdiagnosed, but can also be kind of like concomitant diagnosis. And I think one important lesson from this is that even if the patient already has one diagnosis, if the clinical picture it's kind of deviate from the typical kind of clinical course, and particularly in the region where the disease is more prevalent, should we also do genetic testing to find out the underlying monogenic cause, as we know that the autosomal dominant forms of Alport syndrome, it's kind of like getting more and more prevalent in terms of being identified early by these large sequencing data set.
Yes, Dr. Low was referring to our own findings in Hong Kong to study about the genetic burden of the local Hong Kong population. Interestingly, what we have seen is we have a higher genetic burden on different kinds of cardiovascular diseases compared to the other ethnicities. Things like cardiomyopathy, things like rhythm problem, we certainly have a higher genetic burden compared to, for example, the European population. And we are seeing a very different pattern. It's a different sets of genes, it's a different sets of variants that are more prevalent in Hong Kong that is causing something that we cannot ignore. I guess your beautiful study that you have performed in Colombia, if you do it in Hong Kong, you would be seeing very different things. We have already known from previous work of investigators in Hong Kong that, for example, inherited thrombophilic factors are quite common in Chinese populations as well. And so those would be very important comorbidity that we want to study in Hong Kong.
Yeah, so we've got a new project, right?
It's definitely a new project. And I know that there are more questions, but Becky has already shared her email address, so feel free to refer patients to her and also to talk to her for new exciting projects concerning genomics and nephrology. Thank you very much, Becky.
Yeah, thank you very much, Brian. Thank you very much, all.
So it remains my remaining important job to do some promotion of the Next Gene Club. Next time, we would move to other areas that involve genomics implementations in clinical medicine. We would have Professor Li Jia Chen, Professors of Ophthalmology and Visual Science, Faculty of Medicine, Chinese University of Hong Kong, to talk to us on Genetic Eye Clinic and the Hong Kong Children Eye Genetics Study. Stay tuned. Thank you very much for your kind attendance.